Chris's bio, he is a senior manager at PYA in their Healthcare Advisory Services Consultings Division. Chris works with healthcare organizations to address strategic initiatives in an evolving market. He uses a unique combination of consulting and legal experience to design and implement clinical integration initiatives, public policy projects, mergers, acquisitions, technology and best practices in the delivery of and measurement of evidence-based care for providers. In case you're wondering why we're dialing in, we have a physician with CMS who's going to join us and on the panel later. So we do have a remote person that's going to be joining us as well. Chris, prior to PYA, practiced healthcare law, and before that was a senior analyst at the Advisory Board Company. Many of you in the room are familiar with them, with our hospitals. He earned a Master's of Public Health from Boston University and a law degree from the University of Colorado. And Chris is a board member of the Kansas chapter of HIPAA. That is our sister affiliation in the state of Kansas. So Chris, welcome.
All right. I think we're all kind of getting back in settled here. Now that we have a CMS official on a cell phone that's on my podium here, I think if I'm going to say anything bad about CMS, I can just hit mute and then they won't know the difference. So don't worry about if it gets silent, Dr. Levine. So meaningful use is a teenager in a lot of ways. It's gone through some formative years, but now it's kind of getting to a bit of an awkward point. It might be a little clumsy in a few ways. It might think of itself as kind of invincible, as in the center of the universe, that the rest of the universe revolves around it. And it's really starting to come into its own, and it's in more ways than just sort of a limited regulatory standpoint. It's starting to mean a lot more things to a lot more organizations. And so that's kind of why I titled this presentation, The Other Stage 2 of Meaningful Use. And while I'm going to talk about it from kind of a regulatory and a public policy perspective and even a strategic perspective, after that, Linda will come up in the second half of this presentation and talk about it from sort of within your organizations or within the provider organizations from an operational and more of a functional perspective. So we all probably have friends that have pets that they frequently tell us stories about, and no offense to anyone that's a cat owner in here, but often it seems to be cats. And a lot of times when you give meaningful use presentations, you get this type of reaction from your audience. A lot of times those cat stories seem to blend together and don't always, you can't really differentiate them, and you're not quite sure what the punchline's supposed to be. And so I'm trying to avoid this situation here, and if you can read the caption there, it says, "What makes you think we found your cat story boring?" And the folks around the table are playing checkers and on reading the newspaper and typing on their computers. So this presentation isn't going to be kind of the standard stage 2 meaningful use presentation where we might go through the list of measures and that sort of thing. What we will do, though, is have a brief overview of some of the stage 2 aspects from the final rule. But then I'd like to spend most of our times on sort of this new normal of meaningful use that focuses on increased compliance burdens, also how it's meaningful use is now becoming sort of a platform for other types of regulation that we might not be as used to in healthcare. But then also meaningful use is kind of a standard from a strategic standpoint in things like new care model development, and we'll talk more about that. So we'll breeze through a couple of these slides, and I apologize about the size of the text here. I think I didn't get that edited before I sent this out, but if you could read it, it would say that about 80% of hospitals nationwide registered for meaningful use. Just over half of Medicare eligible physicians registered. That's over 208,000, so a pretty substantial number. And then also almost 100,000 of the EPs registered under the Medicaid program. And I should say, too, that I'm sort of assuming a baseline level of knowledge with meaningful use for the room here, and I think I'm pretty safe there, but if someone needs to interrupt me, please feel free to do so. The dollars that CMS has paid to date exceed $7 billion. 1.4 billion for Medicare EPs, 1.2 billion for Medicaid EPs, and 4.8 billion for the hospitals. So it's a lot of money, and it's important to remember, kind of in this age of austerity, that anytime the federal government is paying for something, they're going to be examining those dollars where they're going. So just something to keep in mind. Also, just wanted to highlight, I think maybe Donna talked about this a little bit, at least in the state of Kansas, but some of the more popular menu items that have been chosen for meaningful use thus far. For the physicians, it's more often the yes-no measures, the check-the-box measures, versus the percentage-based ones. Hospitals had a bit more of a mix, but physicians tend to gravitate towards the yes-no measures, as you might anticipate. So, final rules for stage 2 in sort of one slide. Again, we won't go into too much detail here. One of the big items, more time to get to stage 2 if you started stage 1 in 2011. So you now have until 2014 instead of 2013. The basic structure of achieving meaningful use was retained, where you have the objective measures and then the menu set. The total number of measures actually stayed the same, but they shifted, took away some measures, redefined some measures. But generally, I think that there's a bit more complexity, some higher thresholds on some of the measures. Other big highlight would be the clinical quality measures, the CQM changes. So starting in 2014, those will be reported electronically, and we'll talk a little bit more about that here in the next few slides. So I know I couldn't keep stage 1 to one slide, but you've all probably seen these charts before that sort of delineate the timeline for achieving meaningful use. The reason I like this one and the one on the next slide for the physicians is that it gives you sort of by stage by that green, yellow, I guess it's a pink color scheme, what stage you're in, but it also includes the conversion factor. And then if you see the red boxes down there starting in 2015, those would be the penalties. The bottom row lists the quantification of what that penalty would be. So for instance, in 2015, it'd be 25% of the market basket update for hospitals. If you look at the physician side, that penalty would be 1% of the Medicare charges and increasing by a percentage each year. So, but just wanted to include some of this information as kind of a quick reference, as you'll probably see a lot of this in other settings, vendor presentations and maybe other HIMSS gatherings like this. Also, penalty scenarios, we're really not too far off from the possibility of meaningful use penalties or penalties from the lack of adoption or lack of achievement of meaningful use. Here, if you're already at meaningful use, I think you're just going to have to maintain it at certain levels, and you can see what those levels are here in this chart. But if, for instance, say you're a hospital that is, as a lot are, acquiring more physician practices where you have folks that might not be up to speed on meaningful use and need to start a testing, those timelines for testing, say in 2013 and 2014, in that first column or the second column under 2005, I think are important. So if your first year is 2013, to avoid the penalty in 2015, you're going to have to achieve meaningful use for that 90-day period that you're all probably familiar with in 2013. Now, if 2014 is your first year to get meaningful use, you're going to have to achieve it for that 90-day period again, but it's going to have to be by July 1 of 2014. So a couple timelines there to keep in mind to avoid penalties. Here are a couple, again, sorry about the size of the font, a couple of slides about CQM. So again, the big change, 2013 CQM will be reported basically how you've been reporting it in the past. 2014 and beyond, that's shifting to an electronic format. There's a couple different ways that that will occur, and it's regardless of stage too, so something to keep in mind. You could still be at stage 1 and you would need to report electronically. The kind of an important note here, and we'll talk about this a little more, is that the way that CMS now is starting to coordinate some of the different reporting systems that they're implementing, particularly with things like PQRS, the Physician Quality Reporting System, and also with the quality measures for ACOs. And we'll talk about that more in the coming slides. But here another is a quick reference chart for the physicians from 2014 and beyond on what types of electronic reporting will be accepted by CMS as part of meaningful use. Here's a similar chart for for the hospitals as well. So, stage 2, meaningful use final rule, simple as that, right? So, but here's what just to use that to set the context for kind of the rest of the discussion, and that's that meaningful use is creating sort of a new normal for a lot of healthcare organizations in several different ways. First one I want to talk about is compliance. And now compliance is something we often think about, at least with this group, probably has been most exposed to it in the HIPAA context and the patient privacy and security context, but now there's this other thing out there that's a part of your organization that is funded in large part by CMS that's creating new compliance responsibilities. And we'll talk about sort of what level of oversight CMS has performed to date on meaningful use compliance and where we might see that going in the future. This new compliance burden, it really comes from a couple different sources for the folks in the HIT world. You've got increased transparency, we've got more public reporting, you've got more data capture from a claims data and a clinical data standpoint, so there's just more volume of data out there. Increased consumerism, both from the patients and from payers and from employers. So all the purchasers out there are looking for more value in the dollars that they're spending. And so there's more of a desire to have more information about what they're purchasing. And of course, data security, I'm sure very familiar to a lot of you all, the needs to focus on that with more systems that are capturing data in all of your organizations. Now, I might be shot for this next statement, but the actual attestation process for meaningful use is not that complicated. Of course, getting to that point, very complicated, lots of capital-intensive processes and implementations, but from the provider just to do the attestation, it's really reporting just a couple fairly simple inputs, and it's all housed in the NLR, the National Level Repository by CMS, of course self-reported by the healthcare organizations. For those yes-no measures, you're checking a box. For percentage measures, you're entering numerators and denominators. And then to ensure that your EHR is certified, you've got the EHR certification code that you can then plug in that's then checked against a certified product list that CMS maintains. On the flip side, from CMS's standpoint, that NLR system runs some fairly straightforward edits to that information that you're entering. So that would include things like making sure that those percentage measures meet the thresholds that they're supposed to meet to achieve those particular core or menu measures. And also, if that EHR certification code that you entered is not on the product list, it would fail the validation process for CMS. And that's it. It's not sort of an overly sophisticated system. It's fairly straightforward. So what authority does CMS have to verify that after all of that process has occurred, that you actually did what you said you did as far as achieving meaningful use? So CMS does have authority for post-payment audits. That's the process. There's two types, and this might start to sound familiar, but it's a desk, sort of a CMS-based audit. And then if more information is needed, CMS can go out to the field and check what sort of documentation you have in your organization. CMS recommends maintaining documentation for 6 years to support your attestations for meaningful use. So a timeline there you may want to keep in mind, provide to a compliance officer or someone like that. CMS is planning to do some post-payment audits on a lot of the information that the folks in this room have already submitted. Interestingly, though, at least to my knowledge, they have not performed any of these audits yet. They have a process for doing it, but they haven't done it yet. The process for performing these audits is also fairly straightforward, and it's checking numbers that should be the same. Say for two measures that should have the same denominator, say a volume of patients, they check to make sure that both those denominators have the same patient. Yes?
I know of a couple of hospitals that have been audited.
Okay.
And this was one of the problem areas in that they were looking for that same denominator in these 5 measures. And they didn't seem to understand that sometimes it's a dynamic database, and if you ran reports on different days, you will come up with different
Sure. Yeah, it's a good point. The information that I have here that says that they haven't performed any to date is probably slightly a few months dated because it comes from the OIG report, the Office of Inspector General report that examined CMS's auditing process, and we're going to talk about that here in a couple slides, but that's a good point. Thank you. So as you think about what you might be audited for, keep in mind meaningful use dollars are all or nothing. So it's not as if you achieve 95% of the measures, you get 95% of the money. One hiccup could put all of that money at risk. So I think it's important to keep in mind that it is sort of an all or nothing proposition. Kind of given that background, the Office of Inspector General investigated really CMS's processes for taking a look at how it validates meaningful use among the people that are attesting. And they released this report in November of last year, just a couple months ago, that summarized that report. The final conclusion of the report was that the OIG felt that CMS did not have sufficient safeguards from both a pre-payment standpoint and a post-payment standpoint. Now, CMS has authority to do those post-payment audits right now, and it has sort of some edits on the information that's put in on the prepayment side, but the OIG wanted to see more oversight of how those dollars go out, and we'll walk through a couple of those. The 4 recommendations that OIG made, first was that prepayment audits occur. So they aren't really occurring right now. So some extra layer of validation before the money goes out the door. Second, and by the way, CMS did not agree with that recommendation. Second, that CMS come up with some more specific guidance on what documentation providers need to maintain to demonstrate that they have achieved meaningful use, and we'll talk a little bit more about that too. Third, OIG recommended that ONC incorporate into the certification process the ability for the EHR to produce reports specific to the meaningful use yes-no measures, those check-the-box measures. ONC did agree with that, so something to keep an eye out for in future ONC requirements for certification of the EHRs. And fourth, also improve the certification process of the EHRs to incorporate that sort of reporting functionality in the EHRs. Oh, yeah, sorry, go ahead.
Where can we get a copy of that?
The OIG report? Tell you what, I will email Linda a copy of it after the meeting, and she can circulate it to all the attendees. We'll go through a couple more of the highlights. I thought there was one more back here. Yeah.
You had mentioned that CMS didn't agree to the first requirement of a prepayment audit. Did they have a choice in the matter?
Yet they have a choice whether or not to agree to it. Whether or not they actually happens would probably be above both organizations' heads, I would imagine. And maybe the CMS representative could give us some perspective on that. But generally, the OIG, if you kind of know a little bit about how they work, serves as kind of the internal auditing function of a lot of these other government functions, and could then recommend that this happen and start the ball rolling on particular new policies to be put in place.
So the OIG can't force the issues?
No. But they can force the dialogue is what I would say. But here, I'll show you on this next slide, to your point, the third bullet point down, OIG sort of subtly notes in this report that they actually may just start doing this themselves. Now, they do this in the current world, and from the fraud and abuse standpoint, fairly regularly with things like anti-kickback laws and False Claims Act and all those really scary things that you're told about from compliance officers fairly regularly. But the OIG makes sort of a fairly subtle reference to their thought that they may get into the business of auditing meaningful use compliance. A couple more notes on this slide here. The HHS, Health and Human Services, generally has a push to move away from pay and chase methods of compliance. So that's traditionally how it's happened, is that Medicare reimburses, say, for the service, and then would later go after the recipient of that money for, say, a false claim. So that pay and chase method is basically what meaningful use has right now. And so I think that OIG is trying to recommend that, that CMS move away from that type of compliance monitoring. Another interesting stat, so if CMS had applied its own post-payment audit verification and processes, this idea of comparing, say, two measures with, that should have the same denominator to a prepayment data set, OIG found that 14% of the EPs and 17% of the hospitals would have failed that validation. And that's a pretty substantial number when you think about it. So for documenting meaningful use, if one of these things should occur, an audit, prepayment, postpayment, moving forward, CMS does have a series of sort of recommendations about what to do to ensure that you have the appropriate documentation in place. And a lot of this revolves around those yes-no measures, which for something like clinical decision support may provide sort of a snapshot in time, and there's some worry that it could be turned off, or say like a CDS, clinical decision support, could be turned off day 2, even though you took the screenshot day 1. And so CMS has some recommendations on what to include in your documentation. The risk assessment is another big one. I know that a lot of you went through the risk assessment process before you attested. That's another one that there should be some sort of report or documentation on the risk assessment. And with patient records for those denominator values, some way to show how you came up with that denominator value, particularly from an all-payer standpoint. Some of those are all-payer volume statistics. I think we covered all this. Yeah, OIG did highlight that idea of the alert fatigue, that particularly in the physician context, that for something like clinical decision support, the possibility that a practice could turn off an alert post screenshot or post attestation. So that's one worry that the OIG raised about the process. Another, what I thought was really interesting aspect to how CMS verifies this information is that CMS, according to the OIG, could not point to any data source that could verify any of the measures, a single data source that could verify any of the measures. And when I say that, it's what I mean is that they may have some access to some data sets, like for instance, 25 of the measures, the first row there. Medicare claims data might be able to give them an idea of compliance with 25 of those measures, but it's not comprehensive enough to totally verify it. 6 of the measures were not accessible by CMS. Say, for instance, they may be a private data set, something outside of the CMS organization they don't have ready access to. But 19 of the measures had no data sources that they could currently verify. And so you see how sort of developing this area is for CMS, and why the OIG might have raised some concerns. So audits, right? Sound familiar? If you can read the caption below there, this is a gentleman, and he's speaking with someone behind a desk that has Internal Revenue Service or as the place of work, and it says, "It's funny how two intelligent people can have such opposite interpretations of the tax code." And I think we're going to start seeing some of that with meaningful use. I really do. To your point about the CMS audit that had occurred at this hospital, that well, yes, we accurately captured the patient denominator for that particular measure, but CMS had a different opinion of how to accurately capture that patient denominator value. So just to give you some context about how they might go about performing some of these new audits for CMS, and I'm just assuming that they will come up with different methods, but these are just some examples, and we don't have to go through these one by one, of what the IRS does for audits, so sort of traditional techniques. Diff scoring, so discriminant scoring. So this would be the person that has the house in, here locally, be a house in Mission Hills. You got the Lamborghini. You've got a large mortgage, but you only report a small amount of income. So you take that sort of approach to the meaningful use context, and you could have, hospital with a certain number of inpatient days, pull data off the cost report to calculate the amount of the incentive payment. But then when you look at some of their denominators on the meaningful use measures that were reported, they had very low denominators. So I could see CMS starting to look at some comparative statistics like that. Another one, information matching. A lot of times for your tax documents, you get the same number reported from different sources, say an employer or an investment account. I think now you'll start to see that with some of the overlap in these programs, particularly with the clinical quality measures. CMS checking multiple sources, say meaningful use reports and PQRS or a shared savings program or any number of other CMS initiatives. So just a couple brief recommendations here on the compliance front. So I think it's important to start including meaningful use in the dialogue in your compliance programs. And just make sure it's on the radar of your compliance officer or those committees that meet. I think that's important. Also ensure that whatever attestation documentation you have is consistent with the CMS recommendations to date. That's obviously not a totally clear picture as highlighted by the OIG, and I'm sure as you can attest in your own organizations, but something to keep in mind. Oh, and finally, just sort of prepare in general for more oversight. So what would you want to have in place if someone came and looked at your organization? And not necessarily just from CMS, but maybe state governments, OIG, other parties as well. How much time do I have here?
Oh, plenty of time.
Okay. The next sort of new normal I wanted to talk about is meaningful use as a new platform for, I'll use the term regulation, simply because it's generated from the federal government, but it's a platform for incentivizing certain practices. Here's just one visualization of how meaningful use can connect with several other areas of either regulatory risk or legal risk that's out there. You've got everything from the patient privacy and HIPAA world, where something like a risk assessment needs to be performed before you test for meaningful use, to the fraud and abuse world. Meaningful use systems and EHR systems are capturing a lot more data now, potentially becoming more sources for subpoenaing information. On the employee side, you've got the potential for whistleblowers and snoopers. You've probably experienced this in some of your organizations. The unauthorized web surfing of an EMR is happening more and more, and we see a lot more of that being reported to CMS, and just the opportunity for things like that to occur more. Just wanted to run through a quick example to highlight some of this interconnectedness. So let's say hospital receives its meaningful use dollars in 2011, 2012. CFO is happy. Some hospitals, this is, we've seen some hospitals, this is the difference between positive and negative margins the last couple of years, so it's an important deal. Mid-2012, a laptop gets stolen. It qualifies as a HIPAA breach. It's under a threshold, so it don't have to be immediately reported, but you have to report at the end of the year. By the way, I don't know if anyone saw, but about a month ago, CMS settled a HIPAA breach with less than 500 patients for the first time publicly that I've seen. So it was these smaller volume of patient breaches are now becoming more of a liability, I think, for folks. So CMS investigates the HIPAA breach. That'd actually be the Office of Civil Rights that investigates it, and uncovers that no risk assessment was performed. Of course, we all know risk assessments are required to attest for meaningful use. CMS or the OIG sees in a HIPAA press release from the Office of Civil Rights that says we settled with Hospital A, and these were the things they didn't do correctly, and one of those included a risk assessment, or maybe they just walked down the hall and spoke to their colleague from Civil Rights and said, hey, you should check out this hospital. They didn't do a risk assessment. Well, now CMS and OIG go look and they say, oh, well, Hospital A also attested for meaningful use. And as part of that, they were supposed to perform a risk assessment. They said they did. So now there's the possibility that you're placing all of that meaningful use money at risk. Because remember, it's all or nothing. Now, likely outcome would not be that all of that money would be pulled away. You'd probably settle for something less, but still, you're placing it at risk. It's a new liability out there that's been created by meaningful use. A couple other examples of how meaningful use is connected to other ways that the federal government is regulating right now, or programs that they're promoting. PQRS, I don't know, do folks in the room, are they familiar with the PQRS, Physician Quality Reporting System? How many folks in this room have physician enterprises as part of their organization that are exploring PQRS right now or thinking about implementing it? So a couple, a couple. It's important, okay? Just as sort of a baseline premise, it's something that you really need to take a look at, because there's dollars at stake there, particularly as consolidation occurs with physician enterprises, and the amount that can be placed at risk is more important. So the CQMs for meaningful use, there's a lot of overlap and potential to leverage that investment with PQRS reporting. One of the ways to report PQRS measures, quality measures, is through EHRs. And now there's currently an EHR incentive pilot to report CQMs through, but also they're going to start, I think here on the next slide, ONC is going to start certifying EHRs to be able to automatically report those CQMs. And they'll certify it in a way that you could report those CQMs for both meaningful use and for PQRS. So something to think about, maybe ask your vendor about the capability of the EMR to be able to report those CQMs for both PQRS purposes and in the future meaningful use purposes as well. So just this year, there's again, wanted to highlight PQRS. There is possibility that you've made an investment in meaningful use for a physician group. You might be able to leverage that for reporting some PQRS numbers and may have the opportunity to receive some of these incentives. So you may have the chance to get as much as a 0.5% increase of your Medicare charges, and they're using 2013 data to track penalties that they will assess in 2015, and that penalty could be as much as 1.5%. Then the other area that's important here is that these same measures that they're using for PQRS and for CQMs, at least in part, are going to be part of what's called the value-based modifier for physician groups. If you're familiar in the hospital setting, you have value-based purchasing program now, where it's sort of a budget-neutral program where people are graded on a scale and incentives can go up and down based on sort of a curve. They're going to implement something similar on the physician side starting in 2015. And so it's important to start tracking the performance on these measures so you can make sure you're positioned well once they start keying the payment more towards the PQRS data. Another quick highlight here from a regulatory standpoint. ONC is now interested in improving patient safety through certification processes and other regulatory processes. So this was a report that ONC released on patient safety, I think, pretty recently, in December, that listed several goals that included incorporating safety criteria into certification of EMRs. And another goal, the fifth goal they listed, which I thought was really interesting, is the ability to investigate and take corrective action to address where there are unsafe conditions that relate to EHR technology. Whole new world of regulatory structure. So just to summarize here, this idea of meaningful use is kind of a new regulatory platform that, traditionally when the federal government wants to incentivize certain practices, it uses that power of the purse where, say, for a drinking age at a state, they won't give you highway funding money unless you increase the drinking age to 21. War funding, that happens pretty frequently. That the executive branch wants to pursue some sort of war, but the Congress won't fund it. And CMS has done it too with the way that they reimburse certain services. And now you're starting to see sort of that on steroids, and it's that they're going to incentivize adoption of meaningful use in a way, but they're also going to not leave it there. So there's a feedback now. There's a feedback of data that's being reported, both on the claims standpoint, or the administrative data standpoint, and the clinical data standpoint, that is sort of a new world of transparency that has been sort of opened up the faucet and the pipeline between CMS and your organizations. On the claims and clinical data standpoint, I don't know if folks saw this week in the Wall Street Journal the article about United and Mayo forming their new patient data repository. So United, small insurance company, headquartered in Minnesota, is now starting a data repository with the Mayo Clinic that will have 119 million lives worth of data over 19 years of administrative data, claims data, combined with Mayo is providing 5 million clinical records into this one database. What they're doing is going to create sort of a Bell Labs model, kind of a think tankish, platform for innovation on data analyses. Sorry for the aside, but I think it's just a really good example of how big data in healthcare is really starting to come into its own, and how it's not just happening on the public side, as we're seeing with things like meaningful use and clinical quality reporting and hospital compare and all that, but there's pretty sophisticated efforts out there on synthesizing and then analyzing a lot of this data now, even on the private side. So last area I wanted to cover is meaningful use from more of a strategic standpoint. And again, this is how sort of meaningful use affects your organization, the way it's represented to the rest of the world. And when I say new care model development, these are the kind of things that I'm talking about. So anything from consolidation, mergers and acquisitions work, to ACO development, clinically integrated networks. These are all words that oftentimes have loaded meanings or mean different things to different organizations, but these are some general categories of what we're talking about when we talk about new care model development. I just wanted to run through a couple of these and how meaningful use can be a part of those discussions, and in fact how folks in this room can insert themselves into more of these strategic discussions, and why they should be inserted into more of these strategic discussions as your organizations are talking about affiliations and partnerships and acquisitions with other folks. So we all know consolidation is happening pretty significantly, both hospital-hospital consolidation and hospital-physician consolidation. Also, provider-payer consolidation is happening. You've got Health Partners in California being acquired by, Health Partners is a big multi-specialty group and a Medicare Advantage plan in Southern California that was acquired by DaVita, so dialysis provider, for the low price of $4 billion. There's big consolidation going on out there, and it's from all different types of organizations. But in your world, as you look at what's out there, keep in mind that there is the need to look at meaningful use plans that the organization that you're talking with is addressing as you begin those discussions. And you see at the last bullet point there, the anti-Obama hospital. I worked with a hospital a year ago where the CEO and the board was adamant that they didn't want to have anything to do with meaningful use, despite having a certified EHR and without a ton of effort being able to get to the point where they could attest. And the reason I use that example is that, politics aside, there's money on the table there, right? So if you were in affiliation discussions with that hospital, you'd start scratching your head about, well, what do we have to overcome here? And why is there such resistance to this sort of thing? And there's things like that are out there, these sort of hidden issues with meaningful use that a lot of times present themselves once affiliation or consolidation discussions start happening. A lot of times it's in due diligence too. I can't think of one transaction where meaningful use hasn't been a big part of due diligence. So think about both if you're acquiring an organization or if you are being acquired, do you have the ability to go in and assess an organization's meaningful use progress, where they are, where they need to be, sort of a gap analysis standpoint? but also, are you ready for someone to look at your organization and see where you are? Accountable care organizations, everybody's favorite topic. The ACO, it's important to keep in mind, there are several different types, several different definitions. The definition I like to go with is the 3 bullet points here. So, group of healthcare providers that A, take responsibility for a defined population, B, coordinate care across the settings, and C, are jointly accountable for quality and cost of that population. The spectrum on the bottom there is just sort of a way to plot where that concept exists. If you have provider operational risk on one side and insurance style risk on the other, you're about 1/3 of the way between the provider and the insurer on that spectrum. There's a bit of risk that's new to providers in these types of organizations. And of course, there's a multitude of different types of accountable care organizations out there. The important thing to remember, though, with ACOs is that you're all probably fairly familiar with the Medicare ACO program, the Shared Savings Program. Keep in mind that private ACOs are developing at 4 times the rate of Medicare ACOs. So I think there's 300 or 400 Medicare ACOs now. They just released another 100 last week. So there's over 1,000 probably ACOs out there on both public and private payers. And it's not just with sort of your traditional private payers. You're starting to see large employers get into this business. Self-insured hospitals creating ACOs within their organization with their employee population. So this really is an emerging area, and I think you'll start to see more and more of it. There was one locally here that was announced last week with a group of primary care providers based in the Northland. So this is local too now. With respect to meaningful use, for the Medicare Shared Savings Program, there's 33 quality measures that you're required to report on. One of those quality measures is the percent of primary care physicians who successfully qualify for meaningful use. And the CQMs that you report for meaningful use, several of those overlap with the ACO quality measures. So just another area that meaningful use can be connected with other initiatives that are out there. Here, I won't go through this, but this is a chart of some of those CQMs starting from stage 2 in 2014 in the left column. On the right column are other CMS programs that those measures apply to. So you've got PQRS, you've got ACOs, you've got group practice pilots, you've got all sorts of things. So you can review that afterwards, but it's just to highlight the fact that there's plenty of other programs out there that you can leverage some of these meaningful use investments in. Clinically integrated networks. Some of you may be involved in these discussions, generally groups of providers that stay somewhat independent but then contract with each other to provide collective services or maybe perform clinical protocols in the same method. But clinical integration is really, it comes from a legal concept of preventing anti-competitive conduct by providers. So joint action, so like joint negotiation with an insurance company or divvying up the market in ways that are favorable to everyone. But to achieve clinical integration and pass some of those regulatory thresholds, there's several rules. One of those rules is significant investment in human and financial capital. And the example that's almost always given is the investment in the IT systems. And so start to think about if you're forming a clinically integrated network, particularly ones that have providers that have made investments in meaningful use, using meaningful use as a way to certify that you're meeting some of these requirements. This table here just highlights some of those items that you could use meaningful use in a clinically integrated network as sort of third-party verification that you've met one of these standards. Maybe it's a prerequisite to inclusion in the network in the first place. Private payer contracting and meaningful use. More and more you're seeing private payers include in their contracts with hospitals and physicians some meaningful use related requirement. Some of the large insurers have done this. Highmark, which is the Blue Cross plan in Pennsylvania, required in one of its programs that you include a copy of your attestation with your agreement. also incorporated the CQMs into their best practice program. And what you're seeing is that providers aren't necessarily setting up their own kind of mini meaningful use programs. They're relying on someone like CMS who's put the effort into developing this, but providers have put in the effort to abiding by its requirements and not having to start from scratch. This is not too dissimilar to how providers have approached reimbursement in the past, where, say, they might base a reimbursement to a hospital based on the percentage of the Medicare DRG. So just using the Medicare program as a standard and then adapting it to the private contracting environment. A couple other quick points here, some other programs. Transitional care management, I don't know if some of you are familiar, but there's some new codes available now in the 2013 physician fee schedule that allow for reimbursement for coordinated care post-discharge. This is sort of a new world, and it's real dollars too. It's not a minuscule amount, and we're seeing some networks, integrated delivery networks, start to use meaningful use EHRs as a platform to start to coordinate some of that post-discharge care. Similarly, with the readmission penalty that hospitals are facing, hospitals want to start talking to physician groups post-discharge and how to manage that process better and somehow incorporate that into their EHR system. Value-based purchasing, you'll notice in stage 2 that several of the measures are about patient engagement or the online portal access. These are important things for improving patient satisfaction. And if you know the value-based purchasing program for Medicare, I think it's a third or 30% of the metrics that they measure you on are devoted to HCAHPS, so patient experience, patient satisfaction scores. So just another area where you might be able to overlap some of your meaningful use investment. So I'll end on this. I think it's important to think about what you're going to allow meaningful use to become in your organization. On the left here is this sort of a Trojan horse now. You've been given this incentive money to implement a particular type of technology in your organization, but there's now starting to appear some strings that might be attached to that that weren't necessarily thought of on the front end. Or, conversely, are you going to be able to take it and start to leverage it and be able to take it and increase the return on investments in other areas, say like, you know, a quality reporting program or a clinically integrated network or development of an ACO. So there's two different ways to look at this. I think you can mitigate the risk on the left side, but it takes some planning to come up with the ways that you want to leverage it on the right-hand side. And I think that's it. Sorry if I went long. I think I might have, but any questions?
Any questions for Chris on meaningful use?
Great presentation. I mean, you showed some really nice aspects of this that I hadn't, I mean, I kind of thought of implications, but I especially think that your thought of this as a vehicle for driving lots of other change ongoing, kind of like the way we say, well, you know, you can have your highway transportation money if you make them wear seat belts, that sort of thing. That, I'll bet you're right on that. Quick question, back on the, way back in your talk on the documentation measures for the decision support rule, where you just have to have a screenshot of the rule and they're saying, how do we know you didn't turn it off the next day? I mean, most of the rule systems I've used have audit trails. I don't know if every vendor does or not, but I'll bet they do. Why, do you know, is the OIG or CMS or anybody thinking about simply asking to see the audit trail for that? I mean, I tell you, in the systems I've implemented, I would have no trouble telling you exactly when the rules were turned on, turned off, how many times they fired and everything. We captured all of that.
Sure.
Why did they just ask for a screenshot?
Well, I think, you know, why originally just asking for a screenshot, I think there was a goal to keep it simple. You know, they wanted people to be participating in meaningful use, so we don't want to make it too onerous. To your second point, I'm sure that most EMRs would be able to create audit trails on turning off clinical decision support. And if I had to guess, that may be something that they would include in something like an ONC certification for the type of EHR that we're going to approve as being certified. Yeah. Right. If any of us were OIG investigators or CMS investigators, that might be one of the first things I would ask for. All right.
Any other questions?
Thank you.
All right, thank you, Chris.
Thanks.